Good morning, everyone. Thank you so much for inviting me to be here today to give an overview of our study, which was Avoidable Healthcare-Associated Harm in Prisons, showcasing on behalf of the Greater Manchester Patient Safety Research Collaboration. My name's Dr. Joy McFadzean. I'm a GP from Swansea, and I'm a clinical lecturer of patient safety at Cardiff University. And I'm presenting this talk on behalf of a much wider study team, including colleagues at the University of Manchester. It was led by the Chief Investigator, Professor Jenny Shaw, colleagues at the University of Nottingham, as well as the World Health Organization Collaborating Centre for Patient Safety, Learning and Improvement at Cardiff University, which is led by Professor Andrew Carson-Stevens. Our study was funded by NIHR, and you can see the disclaimer here on the slide. It was a policy research programme grant, and funding was awarded in 2018, study started in 2019, and it ran through until the end of last year. And we're just finalising some of our outputs at the moment. So I was thrilled to hear that this symposium was focusing on tackling inequities in patient safety. And we've already heard some of the excellent work HSSIB are doing, and looking forward to hearing the rest of the talks and the showcases as well. However, more must be done to tackle the inequities faced by people who reside in prisons. Herein I'll refer to as prisoners. You can see on the slide some of the headlines in the news focusing very much on the inequities faced and failings of healthcare, as the media has described. Now, prisons and prisoners themselves are quite a large population. There are approximately 90,000 people who reside in prisons across England and Wales, and they are ageing. They have long-term health conditions. They have physical and mental needs, but as yet, healthcare may not be meeting that. Organisations such as the Royal College of General Practitioners Secure Environments Group emphasise the impact of equivalence of care for prisoners. That is, they should be having care which is tailored for prisoners, thinking about tackling those inequities, in order to deliver equivalent patient outcomes. So what do we do? Our study wanted to focus on understanding the scale and nature of avoidable healthcare-associated harm in prisons. We carried out 3 main phases. The first phase was a focus on patient safety incident reports from prisons in England. So these are events in which a prisoner was harmed or could have been harmed whilst they received healthcare. We looked at over 4,000 incident reports from the National Reporting and Learning System, which is now called the Learn from Patient Safety Event Service, and we wanted to understand what was happening, thinking about the incident type. We wanted to know why the harms were taking place, thinking about the contributory factors, and then the impact for the prisoners themselves, which is the patient outcome. Out of the 4,000 incident reports, over a quarter focused on medication incidents. So prisoners were not having medication prescribed when they should have. If it was being prescribed, there were problems with stock, so the medication wasn't being administered. In prisons, some prisoners may be able to have their medication in possession. They have a little bit of autonomy to take the medication as prescribed. Many do not and need to attend a medication hatch where the medication is administered to them. There were issues with underdoses, overdoses, and the consequences of that. The next top incident type within the incident reports focused on access of healthcare professionals. So whilst in prison, they should have an admission assessment, but they also should have access to GPs, nurses, additional health services as well, and that wasn't happening. When referrals were being sent for prisoners, prisoners were not being escorted from the prison appropriately to their appointments. In prison, you need to be escorted by a minimum of 2 prison officers, often double-cuffed, and if there are problems with staffing levels, or the prison is too busy with security issues, those appointments were not being realised. Focusing on our findings from the incident reports, we started to develop a definition of what avoidable harm in prisons was, as well as, after guidance from the Department of Health and Social Care, a focus on thinking about harm from the aspect of the community, thinking about that equivalence of care concept, as well as understanding the nuances of the prison, thinking about security, staffing constraints, policy constraints that we may not see within the community. We took those findings into phase 2 and carried out the largest case note review in prisons in the UK. 18 prisons were purposefully sampled, thinking about the size of the prison, the security aspects, ensuring that women's prisons were included as well as thinking about the care providers. So some were NHS and some were private provision. Our experienced nurses screened over 15,000 records looking for evidence of avoidable harms. And we had a hunch or hypotheses about which prisoners were more likely to be harmed, thinking about an enhanced criteria. So anyone who has a long-term health condition, anyone who has polypharmacy, 6 or more medications, any prisoner who had died, for example. And so they focused on looking at these records, as well as wanting to compare them to people who didn't meet those criteria, thinking that perhaps if prison is unsafe with regards to healthcare, anyone could be harmed. Then we moved on to phase 3, where we wanted to focus on the perceptions of the people who work and reside in prisons. We carried out interviews with prison officers, prison governors, healthcare professionals who work in the prisons, as well as the people who reside within it, the prisoners themselves. You can see on the slide the objectives of the study. It was epidemiological. We wanted to know what the rate of harm was. We were focusing on the incidence of avoidable healthcare-associated harm. We also wanted to understand, like I've said, with the incident types, the nature and severity of the harms. And most importantly, we wanted to focus on the contributory factors. Why were they being harmed? Thinking that if these could be addressed, could the rate of harm decrease? We published some of our work from the study so far. The QR codes on the side will take you directly to the open access articles. The first 2 publications on the left and the middle are focusing on phase 1 of the study. So that is a characterization of the nature of incident reports, and then in the middle, it's the definition of what avoidable harm is within the setting. And we've also published our study protocol with the methodology of our study very similar to a previous study which was focusing in primary care. Now, when we were asked to give this talk, we were very keen to talk through the findings of phase 2 and phase 3. Unfortunately, they're still embargoed, but instead, what I thought might be beneficial is to focus on our approach, something which I hope complements Rosie's talk just now, which is our focus on a human factors and ergonomics approach with regards to our analysis, as well as where we might start to think about the implications for policy and practice in prisons. I'm sure many of you are aware of this human factors and ergonomics approach. For those less familiar, though, it is trying to consider how the system can adapt to the people within it, not the other way around. We use models such as SEEPS that you can see on the slide. Thank you. SEEPS is the System Engineering Initiative for Patient Safety. And as you can see in the infographic, it's made up of 3 main components, thinking about the socio-technical system, the work system and the domains within it, the processes, also known as work done, as opposed to work as imagined, and then the outcomes. And all 3 of these aspects interact with each other and influence one another. So I'll talk you through what we did with regards to our focus on critical illnesses in prisons, thinking about prisoners who were experiencing heart attacks, strokes, status epilepticus, if they weren't getting their epileptic medication, diabetic ketoacidosis, etc. From the 4,000 incident reports that we looked at from the National Reporting Learning System, approximately 100 of them were involved in some of the most serious incident types. And so what we did was break down the contributory factors, the whys, where it's explicit within the reports, and we tried to map them to the SEEPS domains. So I'll give a couple of examples, bearing in mind the time constraints. With regards to tools and technology, we know that people in prisons often have higher rates of substance use and addictions. In the community, if they have taken heroin or other opiates, whilst in prison, they might be placed on an opiate substance replacement therapy, such as methadone. Prisons rely heavily on equipment such as Methasoft, which automatically you put in the prescription and it shoots out the dose that someone would need to take. Now, what was happening in prisons is the over-reliance of System 1 and duplication of prescriptions. They may have a prescription in the community, and once they came into the prison, another prescription was being issued. But also, they were transferred up to 20 times around prisons in a year, which isn't unusual. And each time, if another prescription was added, the Methosoft software didn't know which prescription they should be using, leading to overdoses and often people needing to be transferred to EDs. Thinking about the internal environment, these aspects of security in prisons, bearing in mind if there is a lockdown situation, so there is a concern with security, every prisoner needs to remain within their cell, but they cannot access healthcare when they need to. And then the external environment, so things such as societal, economic regulations, concepts such as equivalence of care for prisons tries to avoid any prisoner finding themselves in a commissioning gap. Referrals may be appropriate and have been sent. However, if there is no resource to fund the care once the referral is received, the prisoners miss out. After mapping to the domains, we started thinking about how we could make improvements. Thank you. You can see here, if we think about tools and technology again, in prisons, not every prison has an automatic electronic defibrillator, an AED. If someone collapses and their heart stops, they'll be reliant on CPR, but the best thing that we know as academics is they need the paddles on their chest. We need to get their heart starting again. So something as simple as provision and maintenance of life-saving equipment could make a big difference. However, as we know from a human factors and ergonomics approach, making small recommendations like this is not always the answer. The focus should be on a whole system change. We published this in the BJGP, if anyone's interested. So just to finish, the Select Commons Committee said this back in 2018 when our study began, focusing very much on that systems approach, but knowing that a prison sentence is a deprivation of liberty, but not a sentence to poorer healthcare or health. We need to be doing more to tackle inequities and patient safety. So I want you all to be thinking, how can we be more proactive as opposed to reactive, focusing on secure environments, understanding that if this area of society is focused on, then inequalities will be lessened. But you can focus that within your own systems as well. Very happy to take any questions now, or if you want to email me, if you want to find out more, we'd love to return and talk you through the findings of Phase 2 and Phase 3 when we can. But otherwise, thank you very much.